Hey, today we will talk about thermal modalities, which includes, cryotherapy or cold modalities, and thermal modalities, which includes modalities of heat. And you can see some basic objectives here. So really, we'll start a little bit with some thermal modalities here. The introduction, thermal modalities, they help transfer heat, energy to or from tissues, right? Heat actually is not a form of energy, but it's a type of energy transfer. So we'll talk about that in a second. When you place a hot pack, right? If you've ever been in an athlete training facility, a physical therapy clinic, and the clinician has a hot pack, they usually take it out of the hydroculator, right, and put it within a terry cloth, put some layers of towel on it, and put it on the patient. So that hot pack is delivering the energy to the skin. And the skin for the ice pack is a little different. So skin is transferring the energy to an ice pack. Why? Well, one object must be hotter than the other. Higher temperature areas cool to the cooler object, right? So if I take a hot pack plate that's 100 and I don't know, 10 degrees Fahrenheit, we put it on the skin that's roughly 91 degrees. That's what our book says, which is pretty high. It's going to go to the area of cooler object, right? So it's going to go from the moist hot pack to the skin. Vice versa. If I place an ice pack on the body is in my right hand here. Body's 91 degrees. Let's say ice pack, I don't know, 40 degrees. It's going to go from the skin to the ice pack, and that's what's going to make the ice melt if it's crushed ice, whatever the ice may be. The greater the temperature difference, or gradient as they like to call it, the more rapid the exchange. And heat is added or removed from the body in 5 different ways. You have conduction, convection, radiation, evaporation, or conversion. And I am not going in depth into those. That should be some review from physics, right? Even some anatomy and physiology courses. We'll talk about that. This law. So as we get into some thermal modalities, especially like ultrasound, there's a lot of laws. So this Fourier law essentially states that the time rate of heat transfer, right, is proportional to the negative gradient in temperature into the area. So what do you think that means? So in your heads, I'm hoping, so in class, I would typically ask you questions and want your feedback, back and forth discussion, which is kind of difficult here in an online environment. So in your heads right now, I'm hoping that you're thinking, okay, what does this actually mean? How does this Fourier law actually play into thermal modalities with a hot pack or an ice pack, right? So some basic physiology here. We have thermoreceptors in the skin, right? That alters cell metabolism. For every almost 2 degrees Fahrenheit change results in about a 13% increase with heat or decrease with cold in metabolic rate. So if a tissue's metabolic rate either speeds up or slows down, what does that actually do to the human body, right? So again, in your head, what are you thinking? What does that actually do? Does putting, using a thermal modality, heat modality, actually increase the metabolic rate? But what does that actually mean for that specific tissue? Does that accelerate tissue healing? What about decreasing cold? Does that in metabolic rate, right? Does that help slow down tissue healing rate? I don't know. I do know, but I want you thinking in your head. What do you guys think? So our book talks a little bit about the watts per meter of different tissues in the body. So it talks about skin, adipose tissue, and muscle. So the higher values indicate more transmission or energy, right? So your skin is actually pretty high, so it easily transmits energy because of the type of tissue it is. Adipose tissue, which we learn is fat, essentially, is not a good conductor of energy. Excuse me, energy. That is actually important because if we're using a thermal modality in an area of high adipose tissue, it does not transfer that energy as well as it would in an area that we're pretty much on the skin. So if you think of your ankle or your hand is pretty much skin, tiny little bit of fat, and some bone, right? So if I place an ice bag or hot pack on my hand, it's going to transmit the energy a lot better than it would on my gluteus maximus, right, my butt. Most people, their glutes have a lot more adipose tissue. So therefore, it's a little bit more difficult for the energy transfer to occur. So our book talks about the skin resting temperature is about 91 degrees Fahrenheit. That seems a little high to me. And it's influenced by many different things throughout the day. Ambient temperature, what is the air temperature? Obviously, if you're in an area that's a lot hotter, let's say, I don't know, South Carolina, it gets pretty hot there, right? And humidity, so if you're in an area of high humidity, that's going to change your resting skin temperature. Exercise, if you're exercising, your skin tissue temperature will increase, right? Time of day, and even food and alcohol even play a role here as well. So the deeper the tissue, the higher the temperature. So the book talks about the muscle temperature is about 95 degrees Fahrenheit, which is about 5 degrees higher than your skin temperature. Fat, adipose tissue, essentially fat. It just limits the effective depth of penetration of the energy from the thermal modality. Temperature changes at deeper tissues is always less than those with overlying tissues. Right? So if I put a hot pack or ice bag on somebody, the superficial layers, the top layers, are going to get more energy than the deeper layers. Right? So if I take my lateral forearm here, I have a little bit of muscle mass, right? If I place a hot pack here, got some skin, got a little bit of fat, but the superficial layer here is going to get more energy compared to the deeper layer. And that really is the law of Garthus-Draper. The law of Garthus-Draper states that energy that is absorbed by one tissue layer cannot be transmitted to deeper layers. As superficial layers absorb energy, less energy is transmitted to deeper layers. Okay. Superficial, remember, closer to the skin surface. All right. Deeper layers would obviously be deeper. Why is this important? Well, when you place a thermal modality on a patient, hot pack, ice bag, even ultrasound, some things that we'll talk about, this can get important because, let's say you're heating a gluteus maximus and you want to heat not necessarily the superficial muscles, but you want to heat and stretch the piriformis, which is a deep rotator muscle of your hip. It goes from your greater trochanter to your sacrum. So say you want to heat that. It's a pretty common muscle that can be afflicted in sciatica and some other things. But it's very deep. So if I place a hot pack on the patient, I'd probably have to leave that hot pack there pretty long time, and we'll figure that out, for any energy to be absorbed by my piriformis. Law of Garthus-Draper. You'll see it again on quizzes, tests. Cold. So when do you use cold or heat? So cold decreases cell metabolism. We want to use cold when acute inflammatory response is active, before range of motion. So something called cryokinetics. ROM is range of motion, and we have something called cryokinetics. So I can numb your ankle or foot or whatever body part, and then go do some range of motion after it's numb. Why would I do that? Well, I can use the ice to help decrease the superficial nerve endings, and maybe even help increase range of motion. But I don't really use that very often in my own clinical practice. And after physical activity to decrease cell metabolism. contrast baths. We'll talk a little bit about contrast baths, and I really want to know what your thoughts are on contrast baths. Heat increases cell metabolism, remember, right? So we use this when we encourage tissue healing, promotes venous drainage, reduces edema and ecchymosis. So ecchymosis is the bruising, like the black and blueness, right? Improving range of motion before activity, and controlling inflammation in subacute or chronic stages. If I have, you see this a lot with volleyball players. If I have a volleyball patient in the athletic training facility, and a lot of times before practice they want to go put a hot pack on and then on their hamstrings, let's say, and then go stretch and then go to practice. So I can place that hot pack on the patient, and it might feel good, and they might get a slight increase in range of motion, but it's not long-lasting effect. So in my clinical practice, I actually haven't used probably heater ice in probably 4 or 5 years, and I'm really not lying when I say that. If I have a patient that comes in and wants to heat to get loose, well, I have them either go on upper body ergometer, the UBE, or on a bike or UBE until they start sweating. Then I know their body's warm, right? It increases the core body temperature, increases blood flow to various body parts. Then I know that they are warmed up and ready to go play, exercise, whatever it might be. Okay. So cold modalities, cryotherapy is the application of cold modality. They range in temperature from 32 degrees Fahrenheit all the way up to 65 degrees Fahrenheit. I know that seems high, but it's true. Cold cannot be transferred because thermal energy moves from high energy to low energy. Remember, hot to cold. So the ice essentially gets warmer, or the cold modality essentially gets warmer. I keep saying ice because that's the most commonly used modality. So we place a cold modality on the skin. Heat goes from the skin to the cold modality until the temperatures are equal. Once they equal out, we have something else that occurs. Vasoconstriction. So if I take a blood vessel, vasoconstriction occurs, right? The blood vessel gets smaller. Body's natural reaction. Again, autonomic response. We cannot control that blood vessel from getting smaller or constricted. I can't tell my blood vessel in my arm, hey, constrict right now. Decreased metabolic rate, which we know. It can help decrease inflammation, definitely decrease pain, and decreases cell metabolism. Whoa. These flow charts. I don't know if these are more confusing than helpful. I think they are at times. All this is a flow chart that talks about when the initial stage when you put ice or cold application on a patient, what it does for pain, right? Descending pain control mechanisms, and enkephalon closes the spinal gate, and it can decrease spasm or pain. And then on the left here talks about tissue temperature, which decreases cell metabolism. All these things happen due to decreased cell metabolism, increased fluid viscosity, which helps decrease blood flow, decrease in the need of oxygen, which helps decrease secondary injury, reduce cellular output, which decreases inflammation. And all of these eventually lead to either pain reduction or reduction of swelling formation. Remember, once it's there, it's there. This may help reduce formation of swelling. Okay, so through all the rest of the modalities that we talk about this summer, you'll hear the terms indications, contraindications, and precautions. Indications would be why we would definitely use that specific modality. Right. Contraindications would be why we would never use that modality on somebody. And then a precaution would be, okay, I know they may have this, but I could still maybe use the modality if I'm smart about it. So some indications of what or why we would use cold: acute injury, inflammation, acute, chronic, or post-surgical pain. If anyone's had surgery, then you know that it can be pretty painful. Again, to prevent edema formation. Prior to or in conjunction with rehabilitation exercises, right? That's that cryokinetics. Acute or chronic muscle spasm. And neuralgia, which is a nerve, right? Neuralgia, nerve pain. Some contraindications of cold. Circulatory insufficiency. So you already have a patient that has a circulatory dysfunction, disease. We don't want to use ice with them. Deep vein thrombosis. Cold hypersensitivity or cold urticaria. Cold urticaria is actually an allergic reaction to ice. I've seen it. Actually, one of my friends in college at Slippy Rock had cold urticaria. She's an athletic trainer. But she was allergic to cold, ice necessarily. I mean, she could be out in cold, but I remember her reaching into an ice machine, making ice packs, and she'd break out in hives on her hands and stuff. Anesthetized wounds, so if you just had surgical procedure done or a numbing agent injected into you, don't use ice because, well, you can't feel it, right? Chronic wounds, uncovered open wounds, so if the wound is covered, Band-Aid, gauze, whatever it might be, you can use that, especially if you have a sterile environment. Peripheral vascular disease, Raynaud's phenomenon. I'll talk about that in a second too. And lupus. Lupus is interesting. Lupus is an autoimmune disorder, right? Usually characterized by the butterfly rash. A lot of times with ice, using cold with a patient with lupus, it makes them a little bit worse. Okay. So areas we probably wouldn't or shouldn't use them, right? Cold over the carotid sinus, over areas of infection, near the eyes, and avoid treating large areas with individuals having cardiac involvement, respiratory involvement, or hypertension. So large areas would be, hey, here's the whirlpool. Let's go stick your leg in the whirlpool or your whole body in the whirlpool. We don't want to necessarily do that with patients with cardiac involvement, respiratory involvement. In the traditional, high school or college setting, we probably actually don't have many patients that have cardiac or respiratory involvement. Hypertension, actually, yes. Hypertension would be high blood pressure, right? And different environments that an athletic trainer may work in, like a professional sport, definitely you'll see some professional athletes that have both cardiac and respiratory involvement and hypertension. So, you got to know your age group you're working with and their medical history as well. Okay. So this looks like a lot on a slide, but it's going to make sense here in a second. Okay. Magnitude and duration of temperature decrease. So skin is in direct contact with the cold modality typically, right? So the skin is usually the first to lose its heat. As the skin cools, it draws heat from underlying tissues. It goes adipose, fascia, then muscle in that order. Why does it go in that order? Well, if you think of the skin, right below your skin, you have fat, and then you have the layer of covering of the muscle, which is the fascia, and then you have your muscle. The greater the temperature gradient or difference, the more rapid the energy exchange and deeper the effects. So how long do I ice for? Well, I don't ice at all, so I would say never. Okay, the only time I may ice, personally, and again, you don't have to follow what I'm saying because this is my personal philosophy. The only time I would really ice is if that patient is in so much pain I can barely touch them, palpate them to evaluate them. I may ice to decrease the superficial nerve, right, pain, all that, and then maybe I will be able to get a better evaluation. Our book talks about how long between treatments of ice. So they say a 1-to-2 or a 1-to-6 ratio. So 2 minutes between treatments for every minute ice is applied. So if we look at the 1-to-2 ratio, if we apply ice for the standard, let's say 20 minutes, that's what most people say, we need 40 minutes between treatments. Why? Please, in your head, think why right now. So this is a picture. This is an ice pack, right? Placed on the skin, and it's, degrees Celsius. Your skin, your adipose tissue, your thin layer of fascia, and then your muscle, then bone. right? So the ice pack is getting heat gained from the environment, the athletic training facility, or the, if you're outside at football practice, obviously it's getting heat from wherever the environment is. But it's also getting heat from the body, right? So it starts with the skin, it goes to the adipose, then the fascia, then the muscle, maybe the bone, depending on the part of the body, but bone temperature is a lot different than muscle, skin, fascia, right? So all these environments will help actually decrease the temperature of the ice and actually start melting it. The depth of cooling for ice is related to the treatment duration and size of area being treated. As treatment duration increases, the greater the temperature decrease and depth of cooling. Larger the area being cooled, the deeper the cooling occurs. So if we're doing a whole body ice immersion, the whole body, the deeper the cooling actually effect is. Not much on that. Okay, this slide is crazy looking, right? So if we look here, this line on the left here is your skin temperature. The next layer is your subcutaneous layer, fat, right? Bam, right here. And then each one after this is intramuscular tissue temperature, 1 and 3 centimeters, and then with exercise. So we're going to place an ice pack on a patient for 20 minutes. So initially we put the ice pack on, you can obviously see the skin temperature decreasing. So it goes, maybe 87 degrees all the way down to about, 57 degrees. And I know that's 57 for, trust me, I know that's 57 degrees, and you'll find out why in a second. This fascia in the fat layer, the adipose tissue, starts a little warmer. Remember, it's a little warmer. And guess what? Over 20 minutes, it doesn't really decrease that much more. So skin and fat, yeah, definitely decrease. But if you look at the intramuscular here, for 1 centimeter, where'd my mouse go? It starts about 96, 97 degrees, and it only gets down to about 83 degrees, 81 degrees maybe. We can say 80 degrees to keep it simple. If we look at 3 centimeters deep in the skin, it starts about, 96, 97 degrees, and it only gets down to about 90 degrees. Whoa. So why, if I'm trying to cool a muscle, right, why would I cool that? I wouldn't. There's no possible way, physiologically, if you can look at this, yes, you're decreasing the temperatures, but are you actually decreasing the temperature to a therapeutic range? No. We're going from 95 to 90 degrees at 3 centimeters. 3 centimeters is not that big, right? So essentially, you put the ice pack on a patient, skin and fat definitely get cooled. You can see that. But then the muscular temperature, it does not decrease much to a therapeutic range. And that's what all these A, B, C, D, E, F, G, H are, right? Their tissue temperature ranges are benchmarks that are in literature. We'll leave it at that. But you notice after 20 minutes, everything increases. Whoa. So you tell a patient, give them exercises and things to do at home, and they ask you, should I ice? You say, sure. They will definitely ask, how long should I ice for? And you say 30 minutes. Wow, at 30 minutes, let me get my pen here. At 30 minutes, that's supposed to be a straight line, but you can see at 30 minutes, nothing is happening. It's increasing. Skin, fat, temperatures are increasing up to about 75 degrees. That's not good. Does that slide make sense? I'm hoping. I really want that slide to make sense. This is one of the good infographics I like. Okay. Raynaud's phenomenon. It's a vascular reaction to cold application that results in red, white, and blue discoloration. Hey, it's 4th of July weekend coming up here. Red, white, and blue discoloration. Whoa. Raynaud's phenomenon. Some patients might not have a clue that they have this. You put ice on them, and you can easily tell. Their fingertips are turning white, right? So the more distal or further away from your body, the less blood supply. So you see that a lot in frostbite, right? Patients with frostbite lose their tips of their fingers, their nose, ears, toes, right? Because of the decrease in blood supply. This is the same thing, right? Vascular reaction to cold application, extreme red on his ring finger here, and then very, very white tips of the fingers. And even this one has a little bit of red. This is cold urticaria. They placed the ice in a cup on the patient and allowed water to drip down, the ice to drip down, and you can actually see where they broke out in a hive. I believe this is a armpit. Not sure actually. Okay. Skin cooling. Different metabolic factors that affect cooling. We have venous flow. Right? Blood flow carries blood away from the area. So you put an ice bag on. Blood's obviously always circulating. Put an ice bag on, let's say the biceps here. Ice bags on the biceps. Venous flow is carrying it away from the area. And arteries are bringing warm blood back to the area. Right? So it's a constant cycle of warm, cold, warm, cold, warm, cold, warm. Desensitized areas lacking vasomotor function may be overcooled. ACL surgery, classic. The surgeon slices an incision right down the patellar tendon typically, blah, 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 does a whole lot of stuff, closes you up, bam. Most patients after ACL surgery have some decreased sensation of their patellar tendon because some of the superficial nerves were cut just making the incision. So if you place an ice bag on top of that patient, and it's a chemical ice bag, right, or one you might squeeze and the chemicals mix to make it cold, you can actually burn that patient, chemical burn that patient, because they can't feel anything. Now, do you apply ice directly to the skin with a barrier? And how do you wrap it on? I know it sounds nuts. People actually do research in this area. To me, it sounds boring, but it needs to be done. So skin cooling and rewarming. If you apply an ice pack for 10 minutes, you rewarm the area for 10 minutes, and you continue this cycle, there's some research out there that says this could decrease pain, but there's no blood flow that has no capillary blood flow, but has no effect on swelling. So this essentially is contrast baths. So a contrast bath would be you place the patient in cold, ice, whirlpool immersion, 5 minutes. Then you place them in the hot whirlpool for 5 minutes. And you keep doing the cycle, 2-3 times. And theoretically, people thought that it should decrease their blood flow and actually act as a pump to pump out the swelling. Definitely will increase or decrease their pain. Well, there's a lot of research out there that says, yes, it does decrease their pain, but it has no effect on the swelling. People think I'm nuts when I say that. I haven't used contrast baths in probably 7-8 years. Temperature decrease. You have intra-articular and intramuscular decrease. So intra-articular would be over articular joint, right? So as temperature of the joint skin overlying a joint decreases, the temperature within the joint decreases proportionally. Why is this important? Well, we have GTOs, we Golgi tendon organs, we have other things within a joint that could actually affect range of motion, right? So therefore that becomes important, and it actually seems like we get a little bit better decrease in the skin overlying a joint than we do over skin overlying muscle. Intramuscular decrease, so intramuscular temperatures continue to decrease for up to 30 minutes following the removal of a modality. And you could see in the slide a few slides ago, right, that chart I had up there, muscle temps about 1 centimeter decrease about 16.5 degrees Fahrenheit, which may sound really good, but is that a therapeutic level? Compression wrap. So compression wrap decreases the subcutaneous tissue temperatures when compared to just an ice bag alone. Compression wrap means that you place the ice pack on somebody and you wrap the ice on them, right? People actually have done research and they tight compression up to 30 millimeters of mercury. Yeah. Don't put anything between the ice and the skin. In my modalities course that I teach here on my campus, we do this as one of our first labs that we do. We take ice and then we take paper towels and towels or terry cloths, and we have temperature guns. We bought them on Amazon, and we do superficial tissue temperature because we can't insert needles and get tissue temperature that way. We do a normal ice pack on like a quad, and then we do like a foot or ankle, and we look at ice pack alone, ice pack with a paper towel, or an ice pack with a towel. And we do this mainly because you'll have patients ask, oh, the ice is too cold, I need a barrier, I need something between the ice pack and my skin. Don't do it unless it's a chemical ice pack. On a normal ice pack, you get ice from the ice machine. Don't do it. Between the ice and pack and the skin, it decreases the temperature gradient, which slows the transfer of heat and is pointless. It may take you a couple hours to reach a therapeutic level. It's a waste of time for that patient and your resources. We have some benchmarks here. Superficial blood flow decreases soon after the cold modality is applied. And you can kind of see in that chart that it decreases for about the next 13 minutes. So if you look at a chart, put the ice pack on, the superficial blood flow decreases for about 13 minutes, and then small increases of blood flow begin to occur again. We'll get there. There's an important term here. Skin temperature at 57 degrees Fahrenheit. Remember how I said I knew it was 57 degrees? This is why. The maximal decrease in local blood flow is obtained at 57 degrees Fahrenheit. You can easily see this when I do that lab, when we take the superficial tissue temperature of the temperature guns. Very rarely does it ever go below 57 degrees. It may drop to 56, 55, the superficial tissue temperature, and then it jumps up. It's crazy. I've taught this class 5-6 years now, and every year the students think I'm nuts, and then it actually happens in lab, and they can see it, and then they actually believe me. So we haven't had lab yet, but trust me. Hopefully this is one of the labs that we'll be able to do when we're on campus. I know Dr. Caswell and some of the faculty at George Mason are looking at some of the different modalities they have on campus that we can use and play around with. Tissue temperatures. So tissue temperatures, not superficial skin temperature, right? So between 50 and 59 degrees Fahrenheit, maximize the decrease in cell metabolism. Neurological changes begin to occur when the skin temperature decreases about 9 degrees Fahrenheit. So about 9 degrees Fahrenheit change, right, decrease in 9 degrees Fahrenheit, that patient is noticing some numbness, tingling, etc. Maximum analgesia or numbness is attained at about 58 degrees Fahrenheit. Awesome. That's about 1 degree higher than the skin temperature, right? Maximal decrease in local blood flow. Awesome. You can rewarm that for about 60 degrees, and then the sensation starts to return slowly. So if I have a patient that's in a lot of pain, excruciating pain, 10 out of 10 on that pain chart, numeric pain rating scale, right? I can place an ice pack on them. About 9 degree Fahrenheit change, decrease in tissue temperature. The patient notices that their pain's decreasing. At about 58 degrees Fahrenheit, that patient is numb, and as that tissue temperature rises up about 2 degrees, sensation begins to return. That's a very short window. It may be 2 minutes, it may be 20 minutes, depending on the patient and the environment, right? That patient's tissue temperature may actually increase rapidly and they're back having pain. The hunting response is awesome. You will see this. If any of you have I don't know why you would, a temperature gun, maybe you do, for cooking and stuff, but the ones we bought off of Amazon, they're like $14 and they actually work pretty well. You'll see this in real life. You place an ice pack on a patient. In between the 5 and 10 minute mark, almost always the 5 and 10 minute mark, it might be varied depending on the patient, if they're a little weird, blood vessels suddenly dilate. And there's an increase in tissue temperature. So you place the ice pack on them, their tissue temperature is decreasing, and then all of a sudden, bam, it goes up. And then it goes back down. We really don't know why this occurs, but it's awesome. We see this in lab every year. The students think I'm nuts again when I say they take a tissue temperature every 5 minutes. We place the ice pack on for them, each other for 20 minutes. Every 5 minutes, they're taking their tissue temperature, recording it, and doing some data. They notice between that 5 and 10 minute mark, that temperature spikes, and then bam, it drops all of a sudden. And again, literature really isn't sure why this happens, but you will see this, the hunting response. We think it's because the body's trying to protect itself from tissue death, tissue damage, right? Frostbite and stuff, essentially. So that initial spike in the body's temperature is the body's natural reaction of saying, hey, keep me in homeostasis. I don't like this ice. What's going on here? But we don't know that for sure, right? We haven't been able to prove that. Ice sensations in order. Actually, not just ice, cold. Important to keep the order in this because I ask it on my tests, and you see this a lot in the national exam. It goes in order of cold, burning, aching, numbness. All numbness is usually obtained with about 18 to 20 minutes of cold application at about 58 degrees Fahrenheit. And you could tell from that chart a bunch of slides ago now, at about that 20-minute mark, everything started to increase too. It's crazy, right? And it was about 57, 58 degrees Fahrenheit. Cold, burning, aching, numbness. If you don't believe me, at home, get some ice, put it on you, you'll go through these stages. This is why people don't like to ice. The cold really doesn't bother many people, but it's this burning and aching, this middle section here that people really do not like. We're moving slow here. Cell response. So the need for oxygen to the air is decreased, limiting secondary injury. That's the whole goal of a modality or an intervention, at least, is to limit the amount of secondary injury. When cold is initiated within about 30 minutes following trauma, secondary injury can be reduced. You place an ice pack on the patient for about 20 minutes. Our book says cell metabolism is decreased by about 20%, which helps decrease secondary injury. Cold can help suppress inflammation response or inflammatory response by reducing the amount of release of inflammatory mediators, decreasing prostaglandin synthesis, decreasing capillary permeability, leukocyte endothelial reaction, and creatine kinase activity. Again, with blood and fluid dynamics, the arterial vasoconstriction, we place cold or ice on a patient, that artery vasoconstricts autonomically. We can't control that. Yes, the blood becomes a little thicker, increased blood viscosity, so as it becomes as it becomes thicker, the blood is has a more difficult time flowing throughout the body. Therefore, we have a little bit of reduced blood flow, but there's not a lot of conclusive evidence on this, right? The blood flow slows down for about the first 13 minutes, and then anywhere from 13 to 17 minutes, it slowly starts to increase in blood flow. Why? Tissue temperature equals out. That's usually about that 20-minute mark that temperature gradient equals out, right? What about the red skin after an ice bag is removed? You think that has anything to do with the superficial blood flow? I think so. Ooh, formation and reduction of swelling. Cryotherapy substantially limits edema formation. It does nothing if edema is already there, but it limits edema formation. Reduces the effects of muscle inhibition or inability of the muscle to move or be used, right? It does not alone promote removal of swelling, and it can actually hinder the removal of swelling due to the increased viscosity of blood. If you think about it, you're trying to get the blood back towards the lymph and all that exudate, all that crap we don't want, back towards the lymphatic vessels. Well, if it's thicker, it's going to move a lot slower and actually be more difficult to get back to the lymphatic vessels. This can limit the formation of edema by reducing cell metabolism. A decrease in 27 degrees Fahrenheit. Right, the permeability of lymph vessels decreases limits formation of edema. 27 degrees Fahrenheit is huge. We're not necessarily getting that with cryotherapy. This is an arterial and a lymphatic vessel pre-treatment and then 10 minutes into treatment. As you can see with cryotherapy, the arterial and lymphatic vessels are actually getting smaller, right? Do we want the lymphatic vessel getting smaller though? Maybe, probably not though, because if we're trying to remove that junk we don't want in the area after injury, don't we want that lymphatic vessel to be big to actually allow stuff to flow into it? Okay, nerve conduction. Cold decreases the rate that nerve impulses are transmitted and increases the threshold to initiate the impulse. So it decreases the rate, the firing rate of nerve impulses and how they're transmitted. It increases that threshold to initiate the impulse. Now remember that threshold, resting cell, metabolism, negative 70 millivolts, right? That may not happen. It may actually increase. Maybe it increases to negative 75 millivolts, negative 80. But the point is that it increases, so it actually decreases the firing rate of nerve impulses. So instead of being bam, 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 I'm in a lot of pain, place the ice or put them in the cold whirlpool, whatever you're doing for the cryotherapy, and now it's bam, bam, bam. Same thing, pain control, the primary pain control. We've talked a little bit about this. It can remove chemical and mechanical pain triggers. But the secondary pain control, this interrupts the nerve transmission, that bam, bam, and decreases the nerve conduction velocity. When it decreases nerve conduction velocity, the nerve velocity doesn't move as fast. Therefore, you may have a different type of pain. If it's a sharp pain, what does that sharp pain? A alpha, A delta, A beta, C. Look at your little chart that I had gave up on Blackboard a couple of days ago, right? So that secondary pain control using cryotherapy. Muscle spasm. I've had muscle spasms myself. Most people have had muscle spasms, right? Reduces muscle spasms by reducing the number of afferent nerve endings. Afferent to the spinal cord, central nervous system. Decreases the sensitivity of muscle spindles. So a drop at about 9 degrees Fahrenheit reduces the sensitivity of muscle spindles. Therefore, pain can also be reduced to decrease spasm. I've had kind of bad luck with this though. Well, I've had some patients in muscle spasm. I've actually had a lot of patients with a spasm that I've put ice on them, and their spasms actually increased and gotten worse. It sounds crazy, but I've actually used heat. I've had better success using heat on a patient with an acute muscle spasm than I have with ice. Patients, especially with like a low back spasm or a back spasm, they pick something up weird, now their back just tightened up and locked up. I've put ice on a couple of them, actually a lot of them. This always happens with football players for some reason. And this ice actually has made their spasm worse to the point they can't move at all now. So in my clinical experiences, this is part of evidence-based medicine, right? In my clinical experiences, I've used heat, even though it might be contraindicated, but it can help break the pain, spasm, pain cycle. Pain, spasm, pain cycle is pain causes spasm, which causes pain, which causes spasm, which causes pain, right? It's a cycle. If we can break that cycle, we can decrease or stop their pain or spasm. Muscle function. Decrease muscle function after cold modality. So you have a decrease in strength, joint position sense, or proprioception. So proprioception is the body's awareness of itself in space. So if my hand's here in front of my face, I know my hand's here because I have proprioceptors in my joints, right? Each one of these joints, bam, 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 bam. But if I put ice on here and I'm really stiff and might not know where my finger is now. So adequate rewarming should occur prior to exercises. But how many of you have seen a patient, and some of you are newer to 18, that's fine. You might not have seen this yet. Patient ices before they go out and practice or plays. That makes no sense because decreases muscle function, decrease in strength and joint position sense. So now we're actually probably setting that patient up for more, being more prone to injury after icing them and going right out to exercising. How many of you have seen this? Somebody rolls their ankle, sprains their ankle, or has a contusion. They come off, they may ice at halftime of a game, and then they go back and then play. Whoa, now we're actually setting them up for being more prone to injury due to all of these things. Ooh, rest, ice, compression, elevation, don't do it. Rice, baby, all right? Effects of immediate treatment, rice. Oh, the doctor who coined rice back in 1978 has actually came out and said that was the worst thing he's ever done. On Blackboard, I have 3 blog articles that you need to read. They're all by an athletic trainer named Josh Stone. He is awesome. Good writer. It's a blog, but he incorporates evidence into his blog. And he talks about why rest, ice, compression, and elevation is not the way to go. So rest, when you write rice, right, rest limits the scope of initial injury. You may give them crutches, a boot, etc. Ice, little known fact, crushed ice is the best with a little bit of water, almost like a slushy. Yes, people have done research on that. It can decrease cell metabolism and all this stuff that we know. Compression, though, decreases that pressure gradient between the blood vessels and the tissues, and it discourages further leakage from capillary beds into the interstitial tissues. And elevation helps decrease vascular hydrostatic pressure within the capillary beds, and this increases absorption rate, or encourages absorption rate of edema by the lymphatic system. How high should the extremity be? Above your heart, right? Drainage. These two, the C and E, compression elevation, is Starling's law, essentially. If I have a patient that has an acute injury, quickly eval them. I compress, I elevate. I do not ice unless they're in extreme pain. That is me personally. You don't have to follow me. I'm trying to plant seeds in your heads, right? Have you question what's always been done. Cryokinetics, they use the cold therapy with exercise. You put them in ice immersion until they're numb. You exercise until they can feel the extremity. Put it back in the ice immersion. You repeat this cycle 3 to 5 times. We will actually probably do this in lab if we can, and we'll discuss that more when we talk more about the rehab side of a therapeutic intervention later this summer. 2 different things that you can actually injure the patient using cold-related modality. Cold-induced neuropathy. So we have this common peroneal nerve near your fibular head, fibula right, your leg. that is very superficial. So when we actually ice this area, I actually do put a layer of a barrier there because you can actually damage the nerve and cause foot drops. So their foot just bam, bam, bam. Ulnar nerve, same thing. Ulnar nerve right here, elbow, can be very superficial in some patients. So again, you can damage that. Frostbite, normally ice shouldn't do frostbite or cause frostbite because the temperature gradient. Reusable ice packs, though, have a better chance of this. We'll talk about that next chapter. What does the evidence say? Okay, 20 minutes for ice, 15 minutes for ice immersion, and 10 minutes for ice massage. And ice massage is you fill up a cup. Usually we use paper Gatorade cups, right? Freeze them, and then massage into the area once they're frozen of tissue injury, right? Don't do this, though, because you're not taking into account the person's adipose layers, the rate and depth of healing, or not healing, penetration needed. Do not put a layer between ice and skin. 20 minutes is kind of the gold standard, though. All right, but again, you're not taking into account that person's adipose layers. And again, don't put anything between. That's a quick overview on cryotherapy. I know it's been a little over an hour, so it's not very quick, but it is. With the heat modalities, we actually don't have about 44 slides in. Yeah. So with the heat modalities, heat is transferred by 4 different methods. Transfer of thermal energy, chemical action associated with cell metabolism, mechanical action such as therapeutic ultrasound, and electrical or magnetic currents such as diathermy. So thermal therapy is the application of therapeutic heat. People love thermotherapy because, well, people like the way the sensation feels, right? Okay, superficial heat. So superficial heat is like using a hot pack, moist hot pack. Sorry, I keep coughing. Allergies are bothering me. You can use a superficial moist hot pack to heat a large area of tissue, but it limits the depth of penetration. For therapeutic effect to occur, the skin temperature must increase about 104 to 113 degrees Fahrenheit. But a superficial hot pack is limited to about 2 centimeters of tissue depth. So I keep saying superficial hot pack, but it's really a superficial heating modality. A moist hot pack is just one example of a superficial heat modality. So 2 centimeters of tissue depth. So just like ice, when you place an ice pack on somebody, that picture that you saw, that chart, we're probably cooling their fat, maybe the first layer of muscle. With heat, same thing. The superficial heat, it's 2 centimeters is not very much. So you place a hot pack on a patient's hamstrings, you're heating their skin, their fat, and that's about it. Maybe the superficial layer of muscle, if you're lucky. Examples of superficial heat: infrared lamps, which you don't see very often, moist hot pack, MHP, paraffin baths, definitely, and then warm whirlpools. Deep heating modalities, greater depths of greater than 2 centimeters. Ultrasound and shortwave diathermy are 2 that you see. Diathermy is kind of coming back into fashion now. I actually haven't used diathermy very much. Almost every place, actually I think every place I've worked at has never owned a diathermy unit. We've rented a few, for course and stuff like that. So again, this is a little infographic here on heat. Same thing as it's cold, same type of chart that is. And you can read this on your other PowerPoint without me talking about it more in depth, and you can see it better then too. And it closes the spinal gate and pain and all that stuff, right? Indications of heat, why we would use heat. Subacute or chronic inflammatory conditions. So they're having chronic pain, or inflammatory conditions, sorry. Reduction of subacute or chronic pain. Subacute or chronic muscle spasm. They have decreased range of motion. Hematoma, resolution. Collection of blood, right? Resolution. You get hit by a pitch. You get kneed, tackled with a helmet, in football. To your quad, you're going to have an increase there of hematoma, a little bit of blood. Heat actually does help that. And reduction of joint contractures. We see that a lot after surgical procedures. Why you wouldn't use heat? Contraindications, right? Acute injuries, maybe. Even though it's up here as a contraindication, I say maybe. Well, I've used it for acute spasm. That's an acute injury, right? Areas of impaired circulation, peripheral vascular disease, deep vein thrombosis, advanced arthritis, vigorous heating. So we don't necessarily want to use shortwave diathermy, right? And you can see more pregnancy. Interesting. We don't want to increase the core body temperature too much. So if you know a patient is pregnant, should not use heat, especially deep heat. Infection, big no-no. Don't use heat with infection. Areas of precaution, right? Areas of decreased sensation. And then treatment around eyes or testicles. Why you would be heating those areas, I'm not sure. But we still talk about them. So magnitude and duration. When heat is applied, modality, you loses the heat and the body gains the heat. Versus ice, it's the opposite, right? So you place a hot pack on a patient's on a hamstring. That modality, heat is going from the hot pack to the hamstring. And obviously some heat is lost in the surrounding environment as well. You may need an insulator, right? So moist hot packs can cause burns. I have seen this. I personally have not done this, but I have seen this at an institution that I've worked at. One of the athletic trainers did not layer properly and actually caused a little bit of a burn to a patient. One of the clinical sites that we use as our athletic training program, a former, notice I say former, athletic trainer. We never used this person actually as a preceptor, but a former athletic trainer at one of the clinical sites. Same thing. Forgot to give them a terry cloth between the hot pack and the skin, and burned the patient. The patient actually sued, had a little bit of malpractice. They won. Yeah, that person is no longer employed at that institution. Okay. Moist heat pack within terry cloth cover, and then usually between the skin and the terry cloth you have more layers of towel. So that person I was just talking about forgot to put towels down. They put it within the terry cloth, right? So within here. So you can see heat is being lost in the environment, definitely. And then as it gets deeper in the tissues, heat is lost. So your skin, adipose, and fascia layers are going to be get the greatest amount of heat. Your muscle is going to get the least amount of heat. About first 5-6 minutes, your body absorbs heat faster than it can be dissipated, right? So it's absorbing it really fast before it can get dissipated in the outside environment or in the other environments. About 7 to 9 minutes of exposure, temperature gradient evens out and begins to actually decline. Blood comes to the area, stabilize the tissue temperature. Vasoconstriction can occur, rebound vasoconstriction. So about 20 minutes into the treatment, max vasodilation has occurred, and the intensity stays constant. Vessels actually begin to constrict now. So now, about 20 minutes into treatment, it's maxed out. All you can do. The vessels actually begin to constrict, and now the opposite effect occurs. Instead of having vasodilation from heating, we're now having vasoconstriction. I've seen patients laying around with hot packs for half hour because it feels good. Heat is a therapeutic effect, a soothing effect, of course. Now I didn't mention this during ice, but think of an ice pack. You actually have an ice pack on a patient, and say they're icing for, they go home, they put the ice pack on their ankle, they fall asleep, hour later they wake up. That actually has a negative effect. Not people think the more I do it, the longer I do it, the better it's going to be. No. You place an ice pack on that patient. I'll say they. You guys won't ever do this because you're smarter than this. That patient's at home in their dorms, wherever, they fall asleep. That ice pack's been on for an hour now. That ice pack, yes, the temperature's been slowly equaling out, but that ice pack is actually acting as the insulator now. It may actually increase tissue temperature, right? That's exactly what we don't want. Same thing happens here. Well, actually, I should say the opposite thing happens here. The vasoconstriction occurs about 20 minutes into treatment. So these thermal effects are actually important to know. Mild, moderate, and vigorous thermal effect. If I want about a 2-degree temperature increase, I would use this for mild inflammation and accelerate the metabolic rate. If I want a moderate or about 3.5 to 5.5 degree increase in tissue temperature, I would use this for decreasing spasm, pain, increase in blood flow, reducing chronic inflammation. If I want a vigorous thermal effect, 5.5 to 9 degrees, which is crazy, this would be a tissue elongation, so increase in stretch, scar tissue reduction, inhibition of sympathetic activity. Placing a moist hot pack on somebody and then stretching them will not do this. Placing a moist hot pack on a patient may get the mild, maybe to a moderate, depending where the body part is or what body part it is. In order to get tissue elongation, you need a 5.5 to 9 degree tissue difference, temperature increase. How much do you need to raise a tissue temperature to truly get an effect? Capsular tissue, joints, 140 to 158 degrees Fahrenheit. Whoa, we're not getting that with a moist hot pack. No way in hell. Diathermy maybe? Ultrasound maybe? Probably not even then. Collagen tissues, okay, muscle we'll say, 104 to 113 degrees Fahrenheit. So if you place a hot pack on for 20 to 25 minutes, you only get an intramuscular temperature increase of almost a degree, 3/4 of a degree, I'll say 0.72 degrees Fahrenheit at a depth of 1 inch. So bam, they have these therapeutic temperature needles you can stick into the muscle, and it gives you a reading of the muscle temperature, right? Research really does this. We don't really ever do this, and almost never in clinical practice. You place a hot pack on them, 20-25 minutes later, you take it off. You stick the needle in the patient. At 1 inch, not very far, temperature increase is only about 0.72 degrees Fahrenheit. That is not a therapeutic range, right? We're not raising the tissue temperatures to 104 to 113 degrees Fahrenheit. So why do we heat? I don't actually know why people heat. Well, I do know because it's a soothing effect, and that's about it. Effect on injury response. Cell response. For each 18 degree Fahrenheit increase in the skin's temperature, cell metabolic rate increases by a factor of 2, which can release inflammatory mediators. So that may actually be helpful. And inflammation, increase in the oxygen delivery system, stimulates breakdown and removal of tissue debris and inflammatory. Right? That actually is good too. We want that increase in oxygen and removal of tissue debris and inflammation. On body and fluid dynamics, the rise in tissue temperature causes dilation, right? Constriction is ice, dilation is heat, which increases nutrients, oxygen, antibodies, and this occurs more in superficial vessels than deeper vessels. Amount of edema can actually increase, but capability of removal is greater because the lymphatic system and venous system are dilated, if you will, and yeah, it can help move debris out better. Pain control, it has a sedative effect, right? That's really why people use heat or like heat. Spasm, decrease in the sensitivity of gamma afferent nerves, which decreases muscle tone, and pressure on the nerve, which helps decrease muscle spasm. Notice I'm skipping through some of the stuff that, yes, it's important, but I'm not focusing on it as much because I don't think it's as difficult of a concept. Tissue elasticity. Okay, so collagen-rich tissues are heated to about 104, 113 degrees. 5 minutes, plastic deformation occurs. So in order to have tissue elongation, you need to be in this thing we call plastic deformation. not sufficient to decrease contractures or increase tissue elasticity of healthy tissues, right? Place a nice hot pack on a patient, 5 minutes, let's say. There's not sufficient heating in the tissue to decrease contractures, so joint contractures. So if my finger's stuck like this, I'm heating all this stuff, right? Or I should say the muscle, because that's a collagen-rich tissue. I don't have enough heat there to decrease that contracture. So if I stretch like a hamstring, I can't increase elasticity or decrease that contracture because the heat hasn't penetrated deep enough yet. All right. Hopefully that makes sense. There's not a lot of evidence on heat, superficial heat. There's very little evidence supporting superficial heat and tissue depth penetration. There is more evidence on deep heating modalities such as ultrasound and diathermy, but there's very little evidence on a superficial hot pack. So how do we know when to use heat or cold? We don't. There's no clear-cut answers. I can't talk today. It is very individualized per injury, even in the same person. What is your goal of the treatment? You have to ask that patient and understand yourself. Ask yourself, what is the goal of that treatment? Base it on the healing time frames we talked about in the second lecture. Are they in the acute inflammatory response? They just sprained their ankle today. If so, I don't want to heat them necessarily, right? Do I want to ice them because they're in pain? Do I want an elastic wrap? Are they 6 days post-injury, and now I'm trying to help get some scarring and stuff taken care of, so now do I use a hot pack? Or cryotherapy? What does the evidence say? This chapter, as you can see, is really meant to give you the physiological and theoretical basis of thermo and cryo modalities. Next chapter, we will really discuss how to use some of these modalities, how to set patients up, and how to take them through sensations that they may experience with ice or heat, right, and allow you to be safe using some of these modalities. And next chapter, a lot of that we can hopefully do in lab later this summer.